Thank you very much indeed. I think for those of you who don't know Naveen Kumar, he is a very highly respected consultant in spinal injuries, practicing in Oswestry, which is an internationally recognized centre of excellence. And as well as, I think, publishing, researching extensively, lecturing, teaching. You're president of the British Association of Spinal Cord Injury Specialists. You're also, of course, as many of us know, a first-rate medico-legal expert. The downside of that, of course, Naveen, is that everyone wants a slice of you. But the reports are always well worth waiting for. So thank you very much indeed. And over to you.
Thank you. I'll be speaking on behalf of the Spinal Injury Center from the perspective of the rehabilitation, or what you might find it helpful from a condition and prognosis point of view. So spinal injury centers were established as a separate specialty since the center was established at Stoke Mandeville by Sir Goodman. And since then, the service has started to improve, and the number of other specialist spinal injury centers were established in the country. Currently, the service is provided in specialist centers in 8 specialist centers in England, 1 each in Wales, Scotland, and Northern Ireland. And these are offering support for patients with sustained spinal cord injury from the initial period of treatment and rehabilitation and ongoing follow-up and support. Primarily, these were established as centers for traumatic spinal injuries, but over the years, the centers have evolved, and that is also been thanks to the contribution or the development made by the NHS England and to the service specification. As you will see, current service specification as it stands does include Cauda Equina injury, and we do see, rehabilitate, and provide lifelong support in terms of review for persons who suffered injury to the Cauda Equina and or to the conus. See, the spinal injury centers are kind of have evolved, and has the pathways that were developed or established by contribution from the various relevant stakeholders. Various pathways have been designed. Primarily, there are 8 pathways, and then it includes injury to referral to the center, and then review in the outpatient, and then admission, rehabilitation, and then lifelong follow-up, and as well as community support and outreach follow-up. The 8 centers in the UK you will see in the pictures, and where we are located is I work in Midland Centre of Spinal Injuries. This was established in 1965. We are based in Oswestry. We cover a population of the order of about 10 million, and we provide acute care, restorative rehab, reintegration into community, and lifelong follow-up for our patients. There are currently about 488 beds in the UK, and we receive referrals largely from the West Midlands, and that's about the order of about 6 million. The rest of our patients, they do come from the North and Mid Wales, and we receive about 130 to 140 persons with individuals with acute spinal cord injuries. And that does include Cauda Equina injury. Vast majority of the Cauda Equina injuries are seen or referred from the outpatient rather than being electively being admitted as acute. The referrals from the trauma centers, which are traumatic injury to the conus or Cauda Equina, we receive them from the trauma centers, and we cater to the 4 major trauma centers, but mainly from the Cauda Equina point of view. Our catchment comes from Birmingham, Coventry, and Stoke-on-Trent. Over the years, the injuries, the persons with spinal injuries or Cauda Equina, the demographics is changing for us. And before the center was established in 1965, majority of our patients were admitted to the center were younger age group. They were under the age of 50, but subsequent decades, and currently at present, we are seeing individuals who suffered spinal cord or neurological injury to the Cauda Equina at a much later age, and they do have much more comorbidities, and they are much more challenging or complex than what it used to be in the past. So the rehabilitation of persons with spinal cord injury and or Cauda Equina is kind of calls for a holistic interdisciplinary team, and that's primarily because it does involve multi-system impairment. The treatment or rehabilitation is carried out by the team it does include various relevant disciplines from the doctors, the nurses, the physios, the OTs, the psychologists, resettlement offices, and we keep the patient in the center of the heart. So, and then it's based on the principles of structured program of rehabilitation to try and maximize independence and functional restoration for our patients. What we do from a spinal injury center from point of view is primarily rehabilitation. Our main objective is to try and optimize physical function. We educate on life after spinal cord injury or Cauda Equina injuries. So what we do is a structured program of education on various relevant aspects to which is tailor-made or customized to the needs of the individual person with Cauda Equina. And I also aim to minimize the medical complications by trying to identify the complications which they do develop at an early stage and prevent complications where possible, try and enhance emotional adaptation, and that's largely due to the support provided by the MDT, and that primarily from the psychology team. We facilitate social independence, we try and promote reintegration back into the community. So the referral process that normally takes place to the specialist centers, it's kind of there is a pathway which we follow. And of course, all referrals are processed through the national database, but we do recommend that the referral takes place telephone before a referral is made on the national database. This is how the website looks like from the database point of view. The referral is made and they select the trust, and they recognize or identify their local specialist spinal injury center. And then we try and advise on moving and handling referral to the center, and then appropriate and early safer transfer, because the patients with Cauda Equina or other neurological injuries, largely what we get is from the early stages, the traumatic injury to the lumbar spine. As a result, they have got a fracture dislocation or a burst fracture or a hematoma, and/or due to the non-traumatic causes such as hematoma or a spinal infection, where it starts as a Cauda Equina injury, but then the injury, neurological level of injury can ascend, and then it can lead on to a higher level of disability. Hence, we say early appropriate discussion, agreed treatment plan to try and prevent complications, safer and appropriate transfer to an early transfer to the spinal injury center. So what we primarily give importance to or advise the center before the special local hospitals or specialist trauma centers before referring patient to us is an importance of neurological assessment, because it should be carried out at earliest opportunity. It should be clearly documented. It should be carried out by experienced person, and it should be within the first hours to days, because the level can change. Hence the importance of frequent or repeated neurological examination. Even now, sometimes we do see documentation such as just peripherally normal, motor power is plus, or moving 4 limbs, and these can have serious clinical as well as medical legal implications. So we try and advise all centers to try and use the international standards to try and assess neurological disability or impairment for persons with injury to the Cauda Equina and to the spinal cord, of course. The anatomy of and function of the spinal cord is important to try and understand the disability and impairment that are relevant to the Cauda Equina injury, because the tapered end of the spinal cord is usually found at the level of the T12 and the L1. And that's largely because that's where the spinal cord ends as L1, and then the nerve roots, they start in the form of the Cauda Equina. And basically we do have what we call a conus medullaris, which does comprises of sacral spinal cord segments, and it does provide sensory innervation to the saddle area, motor innervation to the sphincter, and parasympathetic innervation to the bladder and bowel. And again, it is important to try and appreciate the relationship between the spinal cord, the conus, and the vertebral column, because there are because the diagnosis of the can vary. That results whether it is from trauma or from a disc prolapse or due to non-traumatic condition, as I mentioned earlier, whether it could be due to a hematoma or spinal infection, and/or complication later on which develops as a result of surgery or a delay such as arachnoid cyst, etc. A typical case of a complete Cauda Equina injury person often experiences the main problem they present to us are as a neurogenic pain, and it can be quite disabling. And they also experience a total loss of sensation from L2 to L5 dermatome. And these are the areas which supply the legs, the feet, the posterior aspect of both of the thighs, the calves, and the perineum. And it can also lead to total loss of motor function below the level of L3 and up to S4 and S5. and it can lead to paralysis of the ankle and toe dorsiflexion. In addition, the inferior gluteal nerve, for example, which is supplied by L5-S1 nerve root, can also lead to weakness of the hip abductors. And if there is involvement of L1, L2, and L3, then hip adductors can also be affected, leading on to the problems with mobility, weakness in the hips, and the risk of falls. Again, these are the important aspects to consider. In the weakness not only affects the toes, the ankle, there is also the involvement of the knee and the hip, depending on the level of the injury that has happened to the Cauda equina. There is often persons with complete Cauda equina injury, they suffer or experience total loss of sensation and control of bladder function, total loss of sensation and control of bowel function. And then the men with Cauda equina, they do suffer erectile and ejaculatory dysfunction. The females, they often experience problems with impaired femininity as a result of Cauda equina injury. So this is the neurological examination chart which we use. It's called International Standards for Classifying Spinal Cord Injury, shortly called INSCI. This was something which came up since 1983. Before that, we used to use a Frankel grading, but since 1983, this is the international standard or de facto, which is used as a standard to try and evaluate all persons with neurological impairment caused to spinal cord, conus, or the Cauda equina. So primarily what we check is from the persons with Cauda equina injuries is the muscles of the lower limbs, that's such as hip flexors L2, knee extensors L3, ankle dorsiflexors, then long toe extensors and ankle plantar flexors, primarily L5 to S1. But the motor function is assessed in the form of presence of sphincter function, that's voluntary anal contraction, what we call VAS, whether this is present or absent. And then again, for a sensory function for the sacral area or the perineal area is checked with presence or absence of the deep anal pressure, what we call as a DAP. And this kind of dark box, what we call S4 to S5, is the preservation of the sensory function for the S4-5 in the form of voluntary anal contraction or deep anal pressure. In addition, the light touch and pinprick for the S4 and the S5. S4 and S5 is usually a 1 centimeter within the anorectal margin. And that's the important area. And then what we check for is S3 is in the region of the ischial tuberosity. Just a picture to show what are the specific dermatomes that we primarily look for. And often the Cauda equina injury persons, usually the impairment starts in the region of the groin, and although it is T12, but sometimes the patients, even though they have got a disc due to Cauda equina injury at L4-5, they have an impairment starting from L1, L2 and below. This is largely because injury to the peripheral nerve behaves as if the patients they experience the pain is along the distribution of the entire nerve rather than just localized to the particular spot. So, but these are the particular zones that we look for in the neurological assessment from sensory point of view. The motor muscles that we usually look for, the hip flexors, the knee extensors, and then the ankle dorsiflexors and the toe dorsiflexors and the plantar flexors from the Cauda equina injured person. As I mentioned, it's important we also check for the hip abductors and also hip extensors in addition to the knee extensors, because they could also be affected in a person who suffered a Cauda equina injury at a higher level injury, primarily from those who have suffered injury from L1 and below. Higher the injury, greater the disability. Lower the injury, less it will be the disability or the impairment. We check the sensory modality for light touch and pinprick using the cotton wool, and then for the pinprick we use the needle, or what we call a neurotip. Wherever you see all these dotted lines, these are the ones which we use. These are recognized as a bony. Usually they are the bony points, or otherwise they are the particular area of the body. So, and then we check for the specific dermatomes for sensory impairment, and then we check for as I said, the S3 is checked on the ischial tuberosity, and then S4-5 is just within 1 centimeter from the mucocutaneous junction. And then we try and grade them after we have assessed the S4-5 function, whether it is complete or injury. Any preservation of function, either motor or sensory, the person would be classed as incomplete. And if none of the functions are present, no motor or sensory, then it will be classed as incomplete. We also evaluate a functional assessment using spinal cord independence measure. It is also used for persons with Cauda equina injury. Largely the difficulty that persons with Cauda equina experience in the section of self-care are to do with dressing and undressing the lower body, bathing upper body and the lower body, or they can do it in a specific or a modified setting. Respiratory function is not impaired in Cauda equina injured person. Again, bladder function can range, management can range from indwelling or suprapubic catheter to ability to void, but majority of the patients, they require intermittent catheterization. And then bowel management, again, it can be regular, irregular, and again, it can be with or without assistance. And then use of toilet, again, range of dependence or independence. Mobility and transfers, majority of the patients with Cauda equina injury are independent with regard to bed mobility, and they are able to relieve the pressures. However, they find it difficult to transfer in and out of the bathtub, for example. Then mobility indoor, it depends. Some of patients can walk indoor using walls and furnitures. Some patients they use with a stick. Some they require ankle foot orthosis or a leg orthosis. And some patients require a crutch, one crutch, two crutch, and some patients they require and Zimmer frame or other mobility aids. And on those who have got greater level of disability and we have got significant neuropathic pain or they have got associated comorbidity, they will they do use the wheelchair. And that again depends from whether indoor or outdoor. Again, there would be variability on a good day and a bad day. And often patients with Cauda equina injury, they experience problem with stair management. They are either able or unable to manage the stairs. Those who are able to manage, they need supervision or holding on to the handrails or a crutch. Again, these are all the assessments which gets carried out as a detailed assessment of spinal cord independence measure. And we also carry out, or I personally carry out the pain assessment using the International Pain Basic Data Set. Because rather than the musculoskeletal pain, which is particularly seen with those who have had long-standing low back pain, but persons who suffered Cauda equina injury, their main problem is the neuropathic pain. And again, this is great. Often the pain starts from the level of either the lower part of the abdomen or the pelvic and genital area, and they're graded either in the midline, right or the left. And then this can depend on the lower back, upper back, and then again from the buttocks and hips. Then again, it goes all the way from the hip, knee, ankle, and the toes. And then they're either classed into musculoskeletal or neuropathic pain. Visceral pain is not seen in persons with Cauda equina generally. So our pain intensity is graded. Then again, there are some quality or pain interference questions which get asked. These are a validated international tool to try and assess or quantify the nature and severity of the pain the person is experiencing. Rehabilitation that we provide is largely focused on the level of injury, and often persons with Cauda equina usually fall into class of either T10 to L2 category, if not to L3 and L4. They are independent or dependent depending on their individual circumstances, because this chart cannot be standardized. There has to be other comorbidities and significance of pain, psychological impact, and body weight and other factors need to be taken into account. So just to try and explain or show a case of a person who suffered a complete Cauda equina injury and has lived with it for nearly 30 years. This was due to a traumatic fracture dislocation of L2, L3. This person wanted to emigrate to New Zealand, but wanted an assessment because the New Zealand declined his initial application for immigration, but wanted to show that he's not dependent on the system basically, but yes, he wanted to show his mobility. But you will see the neurological examination chart, the last normal level or the neurological level of injury was L3. As I mentioned earlier, the spinal cord ends at the lower border of T12 or the L1 junction, and then any injury below that, it usually conus or the Cauda equina injury. So the neurological injury for this person was L3, and it was a complete because there was no voluntary contraction, there was no deep anal pressure, and there was no sensation for light touch or pinprick on any of the dermatomes. So it was a complete injury and was classed as A. So this was an L3 ASIA, but this person, he uses wheelchair for majority of his aspects, but he is able to take few steps and walk. So this is a kind of a problem with the ASIA grading classification. Previous classification would have been a Frankel D, but he's an ASIA A. But it is just to try and show that it is rather than just the neurological assessment, the functional assessment in a holistic way is important to try and quantify the functional abilities or disability of a person. So the rehabilitation is based on what we call in hospitality, what we use is an evidence-based process mapping, where we use a needs assessment checklist. We try and carry out various tasks in terms of trying to educate and improve the activities of daily living, skin management, bladder management, bowel management, translucent mobility, and other skills. These are all focused a process map, and they all start from week 1 to week 12. And there are some outliers, but this is a kind of a structured process to try and improve independence for patients to maximize their independence. So persons with Cauda equina injury, they often they experience problems with the bowels, what we call neurogenic bladder all persons with Cauda equina injury, they experience neurogenic bladder dysfunction. And this is seen in all persons. So these patients are at risk of significant nosocomial or hospital-acquired or urinary tract infections. Often the problem is due to the distension of the bladder, and the bladder can get distended due to catheter blockage as well. So usually we recommend catheterize on admission or on diagnosis, and then leave it on free drainage rather than clamp and release. And when safe, remove the indwelling catheter and commence the regular intermittent catheterization at 4 to 6 hourly intervals as soon as possible. Most patients, they experience what we call lower motor neuron type of bladder. That's largely because the injury is below the level of the reflex arc at the center, and often the detrusor muscle is areflexic. It's either hypoactive or there is also associated with the bladder hypoactivity. The external anal sphincter of the bladder can also be lax. So again, the problem here is over distension. The most common issue here for Cauda equina injured person is an elevated post-void residuals, and they develop recurrent urinary tract infections. And the treatment hence is the regular emptying of the bladder at 4 to 6 hourly intervals. Upper motor neuron type of bladder can occur in persons who have suffered Cauda equina injury, particularly those who suffered at a higher level than the lower level of injury. And this can lead on to overactivity of the detrusors, and there can be uninhibited contraction between the detrusor, which is a bladder muscle, and then the sphincter muscles. And this is what we call in medical terms as detrusor sphincter dysenergia. The commonest problem or the risk for this group of patients is the over distended bladder or a high pressure bladder can lead to what we call reflux, and that can lead to dilatation of the ureter called hydroureter, and then dilatation of the kidneys called hydronephrosis. And this can lead on to renal function, and patient can end up in dialysis. So hence it's important to try and evaluate bladder function. What we do is urodynamic studies as a baseline, if not at regular intervals, depending on the clinical situation, and educate the patient. And then primary function is to try to keep the bladder emptying at regular intervals and keep the bladder pressure at optimal levels. And in addition, that's why for these patients, they get a regular follow-up with ultrasound of the renal tract. The complications that are seen often with Cauda equina injured persons are neuropathic pain, recurrent urinary tract infections, and as a result, they develop stones. And as I mentioned earlier, hydronephrosis and renal failure can be seen. In addition to bowel and bladder accidents, the patients can also have problems with hemorrhoids and constipation if they are not managing their bowels effectively. Often the bowel management is manual evacuation, if not peristine system. Rarely patients who cannot manage and have exhausted all options, they resort to colostomy. But again, the bowel-related complications can occur, and that again depends on the nature and severity of the Cauda equina injury. Osteoporosis is a problem for our patients. That's largely because of impaired mobility, axial loading. Hence, they receive either DEXA scanning and are advised to prevent on the risks of falling. Falls risk is a significant falls with patients with Cauda equina injury. That's largely because they have impaired mobility, they have muscle weakness, they start with foot drop or weakness of the knee, then the weakness of the hip abductors and hip extensors, then they are at risk of having falls. In addition to the motor weakness, they also have what we call impaired proprioception or a joint position and vibration sense. So often we try and check the balance with regard to heel to toe walking, walking on the heel, walking on the tiptoe, walk in a straight line, Romberg test, etc. So the risk of falls is a problem. So falls, if they occur to persons with spinal cord injury or Cauda Equina injury, and on the long term, they can, with the background of osteoporosis due to decreased mobility, the fracture risk is a problem for our patients. So it's important to try and prevent fractures. And pressure sores can occur, but the risk of pressure sores for Cauda Equina is relatively less compared to those who suffered an injury to the spinal cord. But the why it develops is largely due to the impaired the neurological sensation. In addition, there is impaired blood supply. So there's a combination of ischemia and also tissue deformation through cascade of events. It leads to apoptosis or the tissue necrosis. Pressure sores can develop at various parts of the body, and these are largely due to those who have got associated comorbidities, particularly for Cauda Equina. So the pressure sores develop depending on the position, and largely they are all over the bony prominences. And hence these patients are advised on turning, repositioning at regular intervals or to relieve the pressures. Those who are able to walk, and we advise them to try and relieve the pressures. Those who are unable to relieve pressures, they need to take measures to try and relieve pressures. So there are different grades which we use, grade staging of pressure sores. And again, with regard to rehabilitation to try and augment recovery, in addition to education, we try and go through what we call through multidisciplinary holistic approach, an input from the neurophysiotherapist from a spinal cord injury experience, and they often provide education, training, and exercise regime, including body weight supported measures, functional electrical stimulation. We get involved with, for example, we are located in a dedicated orthopedic hospital. We have access to various disciplines in addition to spinal surgery, what we call spinal disorders in osteohistory. We also have access to orthotic department. For example, osteohistory came up with the para-walker system to try, as an orthotic was developed, to try and improve the mobility for those who suffered complete injury. And in addition to that, we also use what we call the ankle foot orthosis. There are a range of devices available, and it has to be individualized or particularized. Again, they go through gait assessment and provision of various orthotic devices to try and provide stability for the ankle and the foot, and also to try and improve their mobility and decrease the risk of falls. In addition to the orthotics, there is a role for functional electrical stimulation. Although the FES system for the spinal cord injury, there is ample evidence and they can get good results. The Cauda Equina injury, the results are still good, but literature in terms of evidence is limited. But that's largely because the Cauda Equina injury, being the injury to the nerve root, they require a higher voltage and a different setting. So there are different FES systems available to try and improve the ankle and foot mobility, to try and maintain independence. That is with or without mobility aids. For the bladder and bowel function, there is this implanted system, what is called as Vocare system. This was used in Imperial College London, but it's no longer used in other centers for a number of other reasons. But again, there are further developments taking place. Hopefully, this will help our patients. I just would like to illustrate with a case example, if I could. This is a story of an 80-year-old retired nurse who suffered a fracture of the T12 vertebra due to a low velocity injury. She had osteoporosis. She tried different pain medications. She was seen by GP, later sent to the pain clinic, and then she underwent a selective nerve root block. This is done through T12 and L1 area, and what we went through is a conus region, and this was a selective nerve root block which was carried out under image guidance. And soon after the injection, and the contrast was injected, and the patient, she became paralyzed. And to start with, initially the document says soon after the injection there was a flaccid paralysis, and then after a few hours later, the level of injury kind of, rather than the conus, it started to behave like a Cauda Equina type of picture. But again, this was an incomplete to start with. The muscles were graded as grade 2 and grade 3. This was from the referring hospital. This is soon after injection, and again few hours later. And she was referred and transferred to Spinal Injury Center. And then we provide what is called as active physiological conservative management and rehabilitation by the multidisciplinary team. And with early and appropriate referral and transfer and specialist input, her neurological recovery was seen. And normally, as we know, grade 5 is normal. And then she had grade 1s and 2s and 3s. And within few weeks, her muscle power improved from 1s and 2s to 3s and 4s and 5s. So basically, there was a lot of improvement. Several MRI scans were done. The first 3 MRI scans were inconclusive. The 4th MRI scan that was carried out with the gadolinium enhanced scan, we kind of picked up a signal change in the distal end of the conus. And that was a very subtle change that was seen. Initial scans were all reported as normal. It was concluded that this was an insult to the vascular due to the nerve root that was injected for the pain, for a back pain to try and relieve, because she was having this sciatica type of radicular pain. And then that nerve root injection led on to development of this type of injury. So she participated in rehabilitation program. She engaged well, and she made a really good progress. And initially, she required a Zimmer frame to start with for walking, and then with the input from the MDT and the therapy program, she progressed really well, and she walks with one stick. She does have problems with balance, and for long distance, she does rely on a wheelchair. Pain is an issue, neurogenic pain. But the good result was achieved with an input from the multidisciplinary team. So this is something which I've published in the Journal of Spinal Cord, and just to try and show the outcome of rehabilitation, which is based on the validated outcome measures called needs assessment checklist. So 100% results were achieved in terms of compliance, but majority of the issues that could not be achieved was with regard to psychological impact, because she often struggled as to why this happened, because she was not consented, she did not understand, it was never mentioned to her. And although this serious complication did develop, she made some good progress with structured program of rehabilitation in a dedicated spinal injury center. This is the video. I'm not sure if I have got the time.
Traveling for my son-in-law his car. And this one, he went to Colorado in a big camper van. And American camper vans are big. And I slept in the back in a double bed. And in the morning, when the last morning, they decided to drive on to start with. And started 5 o'clock because we had a 70-80-hour journey on to Texas. And I stayed in bed, and Andrew started the camper van, and as we were going out to the road, there was a big pothole. And you could see that because it was dark. And went over, and I jumped up, went down, and I noticed straight away that something was wrong with my spine. And it came back. I had to stand with the pain until we got home to Texas. And the doctor thought it was just muscle pain, and he gave me some tablets to take, but nothing else. And in the end, he went home on the train. That was very, very hard as well, painful. He sat right at the back of the train as well, which was bumpy. And asked the stewardess to bring me forward to the front, which I did. And then here they found out I had an X-ray, and I found out I had a spine at T12 was squashed. And then they found out I had osteoporosis, and that made it worse. And I suffered during the continuous pain in my back. And then the doctor decided to give me an injection into the spine, not into the spinal cord, but in the spine. And this went wrong. They gave me an injection. I was lying on the trolley, and when they gave me the injection, I said, I can't get off the trolley. He said, well, why not? I said, I can't move. So that's when the trouble started from here. They transferred me over from to severe, and gradually this faded eventually, and I could walk. First of all, I couldn't walk. And I remember the day when my husband came in and I could walk towards him a few steps, and that was great. And then from then on, it just went better and better. And I went home and I had my roller and tried to walk properly, but it's still unsafe for me to walk on my own. Well, I can't complain about any pain that some princesses provided for me, and the treatment I had was superb. Everything I needed was there. The follow-up was always there. And after 3 months, which I stayed here, I started to walk slowly, with the roller, or with a stick or 2 sticks. But I can't say anything nasty about the hospital because everything was nice.
Sorry, apologies for the delay. So the goals of management that we try and provide in terms of initial management and rehabilitation is to try and ensure maximum neurological recovery, because initial deterioration can happen. So early appropriate referral and management to try and ensure maximum neurological recovery. We try and work for achieving maximum independence with structured program of spinal cord injury and rehabilitation, which is offered to persons with Cauda Equina injury as well. So safer functioning of the various systems that, as I mentioned, bladder, bowels, and other multi-system impairment, and also to prevent complications. And it's essentially a multidisciplinary team involvement to try and achieve a maximum or a better outcome for our patients. Thank you.
That's fascinating, Naveen. Thank you so much. And just have a couple of questions for you, if I may. If you could wind the clock forward by 10 or 20 years in the world of rehabilitation for CES patients, can you sort of see particular key technological or pharmaceutical developments which are just sort of coming into play but haven't become commonplace as yet, and which you might expect to be rather more regular treatments going forward?
Yeah, I think although advances have occurred, sadly, it's not been available for provision for our patients because it's largely to do with funding or resource implications that we do have. The advances that have happened in the world of spinal cord injury and even for persons with Cauda Equina injury have been significant. I think the major advances are in the field of the functional electrical stimulation, the implanted systems of care, which I observed when I went as a registrar from the UK. That was 13 years ago to United States. They were implanted systems and they were applied for persons, particularly those who have had compensation claims and from the insurance. But I do not know what to say, but I think we have not caught up in the same pace. But I expect with time we will embrace the technology and we will be able to offer these latest or better treatments to our patients in the NHS and if not in the private sector.
That's good to know. And another sort of question I had for you, Naveen, is quite often, as you know, there's a big sort of dispute from the causation perspective as to the extent to which ongoing back pain that patients suffer is due to delay in diagnosis and treatment as opposed to just due to the underlying prolapse disc. And this may be as much a matter for John Leach as for you, but it was interesting seeing on his table of symptom prevalence that sort of 80% had lower back pain pre-op and only 25% afterwards. And I was just wondering, from your clinical practice, whether you're able to discern a difference in the levels of back pain that patients might suffer who've had delayed treatment. And I appreciate some of that might be over whether it's neuropathic or otherwise, but what's your clinical experience on
From
that?
the clinical experience, vast majority of the patients, they do tell us that their pre-existing mechanical back pain has gone after they've suffered the neurological injury. But their main problem that they present to us are the neurogenic pain, which is either new or got worse. And they are more common in those who have had prolonged period of compression and those who have had severe compression. So it's the both, I think, in terms of time and also the duration, in terms of severity of the neurological or a nerve root injury. And that is what I see in clinical practice, and that's what we as a team, a multidisciplinary team, we experience. And often they say, oh, I had a low back pain before, but now I don't have that back pain. My back doesn't hurt. Even sometimes when we do clinical examination of lumbar spine, their mechanical pain is not an issue. Tenderness is not a major feature for them, but their main problem is the burning, excruciating pain, numbness, pins and needles, and tingling, which is felt often in the gluteal area, perineal area. For females, sometimes they talk about their vulva, vagina pain, and also they have pain largely in the ankle and feet. And their problem is they feel hot and cold, and as if their walking is an issue. So it's largely neuropathic pain, which kind of either present as a new problem or it is magnified significantly. And I think that depends on, as I mentioned earlier, the duration of compression and the severity of the compression. And that's whether it is a disc, whether it is due to a hematoma, whether it is due to an abscess which was missed in the lumbosacral spine, whether it's a tumor in that area. Vast majority of the Cauda equina injury are the discogenic. But I would have to defer to John Leach on that particular causation and liability issue. But from my clinical experience, usually they say low back pain is either decreased or absent after they've suffered Cauda equina, and the neurogenic pain is new or it's got worse.
That's really interesting. Thank you so much, Naveen, for taking the time out to join us. I'm very grateful to you.